Welcome to meeting number 6 of the Special Joint Committee on Medical Assistance in Dying. Pursuant to the order of reference of the Senate Chamber adopted on February 26, 2026, the order of reference of the House of Commons adopted on February 13, 2026, the Special Joint Committee is meeting to study the eligibility of medical assistance in dying for those whose sole condition is mental illness. Today's meeting is taking place in a hybrid format. Pursuant to the standing orders, members are attending in person in the room and remotely using the Zoom application. I'd like to confirm that sound tests have been made successfully. Before we continue, I would ask all persons participating to consult the guidelines written on the card on the table. These measures are in place to help prevent audio and feedback incidents and to protect the health and safety of all participants, including interpreters. You will also notice a QR code on the card, which links to a short awareness video. I'd like to make a few comments to the benefit of witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. For those on Zoom, at the bottom of your screen, you can select the appropriate channel for interpretation, floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through myself, the chair. For members in the room, if you wish to speak, please raise your hand. For members on Zoom, please use the raise hand function. The clerk and I will manage the speaking order as best we can, and we appreciate your patience and understanding in this regard. Tonight, I would like to welcome a whole bunch of new Liberals over there. Greg, Wade, Elizabeth, Peter, welcome to the committee. I'd explain who's who, because some are here permanently, some are not here permanently, but it gets too complicated, so I'm just going to forego all that. For the first hour, we have 3 people testifying. In the room, Professor Brian Mishra, Director, Center for Research and Intervention on Suicide, Ethical Issues and End-of-Life Practice, Université du Québec à Montréal. Online, Center for Addiction and Mental Health, Dr. Sanjeev Socklingham, Senior Vice President, Education and Chief Medical Officer by video conference. You will each have the floor for approximately 5 minutes, as there's only 2 witnesses. You can go a little bit over. I will just raise a piece of paper when you have about 30 seconds so you know your time's coming to an end. With that, maybe we'll start first with Professor Mishra in the room. You'll each have your 5 minutes, and then there will be a series of questions. So, Professor Mishra, you have the floor.
Honorable Senators and members of the committee, I've spent my life working in suicide prevention. I was president of the Canadian Association for Suicide Prevention and the International Association, founder of the Quebec Association for Suicide Prevention, and I work with the World Health Organization in training, research, and policies. I believe that MAID should be available when suffering is not remediable by other means. However, in the case of mental illness, this is not possible to determine. I believe that suicides are preventable, even in seemingly hopeless situations. And I agree with the position of the International Association for Suicide Prevention that the overlap between MAID requests and suicide makes it impossible to distinguish between them. And that MAID for mental illness will undermine suicide prevention by communicating that death is a viable alternative to treatment. I don't think I have to say much about irremediability. Other people have talked about its impossibility to be determined with mental illness. No one can accurately predict whether a patient who failed to respond to multiple past treatments will respond to the next treatment or not. Mental health diagnoses change. They are unfortunately unreliable. Common diagnoses like schizophrenia. If you ask 2 psychiatrists to independently make a diagnosis, in about 1 out of 7 patients, they will make different diagnoses, which means that many people get the wrong treatment unless or until their diagnosis is corrected. 86% of mental health patients have at least 2 diagnoses over 34 years. According to research, no one virtually gets and keeps one pure diagnosis type. We have an obligation to provide access to mental health treatment before providing access to MAID. The Canadian Institute for Health Information in 2025 found that 41% of adults with a mental illness said that their needs were not met at all or only partially. 52% of young adults reported not being able to obtain any or only limited help for their mental illness, and 1 out of 3 Canadians say that they did not have access to mental health services because they are unable to pay the costs. Some believe that requests for MAID are more reasonable or rational, and this can be distinguished from suicide. However, there is no discernible difference between the reasoning in MAID requests for mental illness and justifications given for suicide. And both people feel their suffering is interminable and intolerable. Moreover, most important human decisions are emotional, not rational or reasoned. What's the most important decisions we make? Who we marry, career choice, even what type of car we buy. We cannot expect that while we are suffering from a mental illness, and mental illnesses can cloud one's thinking, things should be any different than other important decisions we make. I held the Boer-Alaskan Canadian National Fellowship in Human Rights Research to study euthanasia in the Netherlands, where MAID for mental illness was legalized in 2002. Each year, only 1 or 2 requests were approved. However, recently, after news stories about people with depression who received euthanasia, requests skyrocketed in 2023 with 138 deaths, and in 2024 it went up 60% more with over 7,000 requests and 219 deaths. Most of the people who died and who requested it were depressed women living alone under age 24. Alarmed psychiatrists petitioned the government to stop this practice. They said, introducing euthanasia as a sanctioned outcome reframes suicidality from a symptom requiring containment into a potential treatment endpoint and as an acceptable treatment plan. I don't want this to happen in Canada.
Thank you, Professor. Dr. Socklingham for 5 minutes.
Thank you, Chair and members of the committee, for the invitation to appear today. My name is Dr. Sanjeev Socklingham, and I am the Chief Medical Officer, Senior Vice President Education, and Senior Scientist at the Center for Addiction and Mental Health, CAMH. CAMH is Canada's largest mental health teaching hospital and one of the world's leading research centers in this field. I also oversee our medical assistance in dying service here at CAMH. Over the past number of years, CAMH has made several submissions to government committees related to medical assistance in dying and mental illness. Our position has been and remains that we are concerned about the expansion of MAID to people whose sole underlying medical condition is mental illness. We want to be clear that this position is not based on the belief that suffering caused by mental illness is not comparable to suffering caused by physical illness. The grievousness of an illness is subjective, and there is no doubt that for some people, mental illness can be grievous and cause physical and psychological suffering. The irremediability of an illness, however, is an objective determination that must be based on the best medical evidence available. And right now, there are currently no established criteria or consensus among psychiatrists for if or when a mental illness should be considered irremediable. That is because there is no evidence in the mental health field at this time to predict the trajectory of any one person's mental illness and to ascertain whether an individual has an irremediable mental illness. And this has been discussed previously. Therefore, any determination that a person has an irremediable mental illness for the purposes of MAID would be inherently subjective and arbitrary. In an attempt to address this problem, the Canadian Psychiatric Association, CPA, recently published initial guidance designed to help MAID assessors identify if a person has an irremediable mental illness. I know this has also been discussed by this committee. We appreciate the CPA's efforts to create clarity around the process of an assessment. However, it does not address our call for creation of guidelines summarizing the evidence gap. Specifically, the guidance document does not offer MAID assessors with evidence-based criteria that could be used to determine the trajectory of a person's mental illness. And the CPA guidance only provides recommendations on a process to follow for assessing a person's mental illness. And this leaves the guidance open to individual interpretation and could put people with mental illness at risk of accessing MAID when they do not actually meet the eligibility criteria. The lack of evidence for how to objectively determine the irremediability of an individual's mental illness is a primary reason we remain concerned about the potential for MAID to be extended to people whose sole underlying condition is mental illness. And this concern is compounded by disagreement amongst physicians on if or how a request for MAID can be differentiated from suicide intent, which is an extremely difficult task for psychiatrists. In fact, a new review of the research literature found no evidence to suggest it is possible to reliably distinguish between the factors underlying a request for MAID and those underlying suicide intent. While the CPA's first edition of MAID clinical guidance has a section on managing suicide risk across all phases of the MAID pathway, it does not provide concrete methods for helping clinicians to determine if the request for MAID is due to acute distress, a symptom of a mental disorder,
Sorry, Dr. Socklingham, there's an issue, I think, with translation.
Oui, Monsieur le Président. Si le témoin peut juste ralentir un petit peu parce que c'est difficile pour les interprètes de maintenir le rythme.
It's very difficult for the interpreters to follow.
So
Would you like me to slow down a little bit?
Yeah, please.
Okay.
We'll give you a few extra seconds at the end.
Okay, thank you. Thank you. Would you like me to repeat any previous statement, the last paragraph? Would that be helpful?
Maybe, how about the last paragraph?
Yeah. So as I was saying, a new review on the research literature found no evidence to suggest it is possible to reliably distinguish between the factors underlying a request for MAID and those underlying suicide intent. And while the CPA's first edition of MAID clinical guidance includes a section on managing suicide risk across all phases of the MAID pathway, it does not provide concrete methods for helping clinicians determine if the request for MAID is due to acute distress, a symptom of a mental disorder, or an enduring desire to die. Finally, but of utmost importance to extending MAID to people whose only medical condition is mental illness, is the state of mental health care in Canada. We've heard mental health has been and continues to be significantly underfunded compared to physical health care in our country, making it difficult for people to get the right care when and where they need it. Demand for care continues to grow while service capacity does not. 1 in 3 Canadians report that their needs for mental health care are unmet or only partially met. In Ontario alone, over the last 4 years, mental health service volumes have increased by 66%. Access to mental health treatment also remains inequitable. That is why investing in mental health care and support should be the priority before any consideration is given to moving ahead with implementing a track to choose MAID. In sum, only when we have evidence-informed, consensus-based criteria for determining the irremediability of a person's mental illness and for distinguishing between a request of MAID and suicide intent, and only when such criteria could be introduced into a well-resourced mental health system, would it be possible to offer safe, adequate, and equitable MAID services to people whose sole underlying condition is mental illness. And that is why CAMH recommends that the federal government delay indefinitely the extension of MAID eligibility to people whose sole underlying condition is a mental illness. We are at CAMH are happy to offer expertise to the government, including sharing our recent evidence synthesis on irremediability, suicide, and MAID, and the gaps in the evidence base when available. Thank you.
Let me say, I think we'd be happy to, if you want to submit that, we'd be happy to receive it. Now we go to our first round of questioning with Mr. Lawton for the Conservative Party for 5 minutes.
Thank you very much, Mr. Chair, and thank you, witnesses, for your very, very fascinating and well-informed testimony. I'll be devoting my time to asking you questions, Dr. Sokolingam. I just want to put a fine point on how you ended there. Your position, or CAMH's position, rather, is that we should delay indefinitely the expansion of MAID for mental illness as a sole underlying criteria, and that's correct?
That is correct.
We have heard testimony overwhelmingly from psychiatrists in particular that have alluded to the very things you've alluded to here, that there is no reliable way to distinguish between suicidality as a symptom of mental illness and a good faith request for MAID. We've heard the impossibility of coming up with a standardized framework that would assess irremediability for mental illness. Would you say from your experience that we have as close to a consensus as possible from mental health care practitioners of these points?
I would say so. And again, we've done our own assessments within our institution. And this is what has come forward as a majority in terms of some of the concerns. And I would say, again, it's due to the lack of evidence that we have to really delineate between suicide intent and the request for MAID. And as you articulated, our ability to prognosticate irremediability is significantly limited, given changing diagnoses, diversity in access to treatment based on geographic region or sociodemographic factors, but also in terms of predicting response.
So, I mean, obviously, on a very charged subject, it can be very difficult to find consensus. But we do actually have a fair amount of consensus to delay the expansion. My question to you is, looking at what CAMH said in 2024, or ahead of 2024 rather, that 2024 was too soon. The government delayed it and delayed it again. Here we are with an extension yet again to 2027. You are saying that we should delay indefinitely. Is your view that these issues can ever be resolved, or should we be really looking at a permanent cessation of this and end this practice of kicking the can down the road and just saying that by design this could never work?
I think that's you're asking me to prognosticate on the research and science of mental health conditions, and I don't think I can definitively say when or the timeline for us to really tackle and articulate some of the key things, particularly around irremediability, for example. I think we are suggesting indefinitely, and I apologize if there's I'm at the hospital right now and there might be an announcement overhead, so apologies if there's any distortion here. I would say for irremediability, I would say that we do not have sufficient evidence to prognosticate. There are still debates on diagnoses and differentiation of diagnoses among psychiatrists and assessment. And until we have a solid research to identify people's trajectories, biomarkers, and improve our diagnostic assessment tools and clinical assessment tools, I think the notion of providing safe guards for MAID for mental illness will be severely limited. And I'm not, why we're saying indefinitely is because the timelines for that to occur, for the evidence to mature and to have that stability and safety will take a significant amount of time. So kicking the can, as you said, down another 3 years, I don't think will substantially make a difference because we need to invest in research significantly.
Some of the testimony we've heard from people who are not on the front lines of seeing patients with severe mental illnesses as you are, but some of the witnesses who have approached their testimony more from the realm of legal theory have said that, we can't discriminate between physical illness and mental illness. Now, CAMH in its 2023 submission said that mental illness, healthcare for mental illness is not comparable to care for physical illness. And I don't take from that you were saying that the two are unequal on a moral level, but in a practical sense, there are significant differences there. Just in the 30 seconds I have left, could you please elaborate on that in this context? You're muted, Doctor.
I'll be very brief on that. And in some physical health conditions, we have diagnostic markers, lab tests that we can do to confirm a diagnosis and prognosticate someone's response to treatments. We are not there in mental health and for mental illness. And in particular, mental illness is more defined by differences in inequities in terms of access to treatments as well that are probably more pervasive given the nature of the illness and socio-demographic factors that are impacted.
Thank you, Mr. Lawton. Now for 5 minutes, Ms. Tezer-Dirksen.
Thank you very much, Mr. Chair, and thanks so much to our guests who are here today. I want to follow along with what Dr. Suckelingham was talking about with respect to the CPA guidance document, which I've reviewed. And in particular, I want to talk a little bit about Section 2, which was the guidance for assessing and managing the suicide risk of the requester. And I've written down here a portion of the document which noted that jurisdictions that allow assisted dying for persons with mental health disorders as the sole underlying medical condition have found that most requesters have a history of suicidal ideation and or suicide attempts. However, the presence of a history of suicidality does not prevent the requester from being eligible. So I'll ask you, Doctor, in your opinion right now, and you've kind of touched on it a little bit, but my question is, do clinicians and providers have the tools available to make these assessments and determine them with some degree of accuracy, particularly given in a more historical context of previous suicide attempts?
Yes, I think a great question. I think in the context of previous suicide attempts, I think much of our assessment is retrospective as it relates to mental health conditions and prognosticating from that standpoint. I do think from the standpoint of using past suicide attempts or suicidality, it is difficult to untangle what the current request for MAID is from an active suicidal ideation or intent, because it's so intricately embedded in some of the major mental illnesses like depression, high rates of suicidality in patients with schizophrenia or psychotic illness as well. So what I would say is it is difficult for us to entangle that on the front lines in terms of whether someone's request for MAID is in fact no longer part of that past suicide intent, and is it part of their current suicidality, really difficult in the front lines, and I would say validated by our clinical experience as well in our clinical setting.
Okay, thanks for that. And I know you had mentioned that with respect to understanding or untangling irremediability and untangling suicidality with a more reasonably based request, the research is kind of still out. Is there research underway? Like, is there a plan? Are researchers actually looking at these? You mentioned biomarkers and different things. Like, how developed is the research right now? Or is this something that we're not going to see for decades?
That relates to the previous question as well, that I think we have some signals of where we might be able to do research. We continue to request more funding and resources to do that research, to advance it, but it is still in the preliminary phases. And for it to be widespread into clinical practice, that is why we are recommending suspending this indefinitely, because of the time needed for that research to evolve.
Thank you. And you mentioned funding, and that oftentimes some of these discussions come down to that. I do want to ask, because it's within the scope of this committee, it's a particularly important scope of this committee to determine whether or not provinces and territories are ready to offer these services, provide the assessments, whether they have capacity to do the assessments. So I'll ask on that basis, you mentioned funding already, but aside from funding, in your opinion, the provinces and territories that in Ontario where you have experience, have you seen a willingness of the province to address this, or does it appear that they are still far away from implementing the systems and guidance that are needed for clinicians and providers to make adequate decisions?
Adequate decision about MAID for mental illness I actually sat on our provincial committee to tackle this question with our government, our Center of Excellence for Mental Health and Addictions, and a local network as well, committee of our major hospitals, to tackle this very question, and co-chaired that local committee. And in fact, we advocated for consideration when there was a high likelihood or a push to consider MAID for mental illness implementation a couple of years ago. We were worried and really wanted safeguards in place and resourcing because of the concerns I'm expressing today. And there was not a willingness to put resources forward. And in fact, one of our other concerns is that this pathway, if it were to come to fruition, would be a way for people to bypass the long wait lists for mental health treatment to get assessment. They would actually get assessment faster in some cases than those who are waiting years for mental health assessment and treatment. And so we really need to think about the pressures in our healthcare system, how we would prioritize something like this versus providing and rolling out treatments that are effective for treatment-resistant depression, for example, which really links to irremediability. And so these are the kind of ethical but financial considerations we have to make as a system as well.
Thank you. Madame de Bellefeuille, vous avez la parole pour...
Ms. de Bellefeuille, you have the floor for 5 minutes. Thank you very much, Mr. Chair. My questions will be for Mr. Mishara. You undoubtedly understand what I'm trying to express here. If I have a chronic illness that's incurable, persistent, I can make the choice to die with dignity and choose medical assistance in dying. If I get a diagnosis of dementia, Alzheimer's, and I'm a Quebecer, I can have an advance directive to die in dignity when I don't want to die in a long-term care home. I want to recognize my children and husband. I don't want to be incontinent and have bad quality of life, even in a long-term care center. I have the right to choose. The law allows it. But if I'm schizophrenic and I'm under the care of a psychiatrist and I'm well medicated, I'm followed by the team of my CLSC, and my loved ones are with me, but that despite all that, I'm suffering. I've been suffering for many years. Well, I come to the conclusion that I don't have the same rights as other citizens who are in a situation of suffering because psychiatrists, doctors can't agree on a clear framework to determine whether my cure is still probable. Maybe other attempts can be made so that I suffer less. What bothers me, doctor, is to create categories of citizens who don't all have the same rights. I understand the question of how it's more difficult to decide whether someone with that kind of history can obtain MAID if their only problem is a mental disorder. But right now, as we speak, there are people who could obtain it because they have everything required but don't have the same rights as others. That bothers me. What can you tell me to try to have me understand that those people are not being discriminated against? Right now, it's not true that there is no research. There's lots of research. But all the research to date indicates that no one can really know whether in 6 months or a year or with a different treatment, that person will not be very glad to be alive. Given difficult access to medical treatment for mental health, we have an obligation to do everything to prevent suicide. Any person who attempts suicide thinks exactly like the person that you're describing right now. The person thinks, I can't continue to suffer this way. Death is the only way to stop my suffering. And there's nothing to be done. But almost always, we can, in fact, prevent suicide. I'm not talking about that. I'm giving you an example here. Somebody with schizophrenia, who's been treated for 25 years, who's medicated, who's well surrounded. As a legislator, I feel uncomfortable not listening to that person and their will to say, I've had enough. I'm suffering every day despite all the help I'm getting. I'm wondering what I can say to that person. That person needs to hear the message that everything will be done to help them. That person needs access to good diagnosis services. Yes, I'm sorry to interrupt you. I only have 5 minutes. But you're taking something for granted here. I've seen people in my office who had consulted doctors, who'd had intensive follow-up in mental health for 20, 25 years, and who are still suffering and remain suffering. So I'm saying those people, why aren't they authorized to be taken into consideration as a full-fledged person who can make choices? These are personal choices that concern them. When you've been treated for 25 years by a psychiatrist, you're getting medication, you have loved ones who are helping you, but you continue to suffer. What kind of hope can I give those people? Well, I think that person could speak to many others who've testified before the Parliamentary Commission in Quebec. Quebec decided not to allow MAID for people whose sole medical issue is mental disorder. We had testimony from people who were exactly in the situation you've described and who said before the committee, if MAID had been accessible for someone with a mental health problem, I'd be dead because I meet all the requirements 3 years ago. But now I'm very glad to be alive. I got proper treatment. And if we could predict who would be glad to be alive in a year or 2 years and who will continue to suffer, that would be another matter. But up till now, all research indicates that's not the case. And even research on schizophrenia indicate that the symptoms can reduce with age.
Et ça, c'est l'autre.
After that, the next person on the list is Senator Dalphon for 3 minutes. Good evening. Thank you for being with us, to all our participants. My question is for you, Professor Mishara. You closed your presentation by referring to data from the Netherlands. Could you elaborate a bit on that? You're talking about exponential growth after 1 or 2, 3 cases a year, and now it's much larger numbers. Could you explain that, give us more details, and give the committee the source of this information? I could send the references. In the Netherlands, they have a long assessment process. It can last up to 2 years. They accept 3% of the requests, and even that is controversial. But suicide is a phenomenon. There is this phenomenon called the Werther effect because of this book by Goethe, The Tribulations of Werther. When it was published more than 200 years ago, there was an epidemic of suicide in Europe afterwards, in all countries where the book was published. These were young people. I'm sorry, my time is short. I'd like you to get back to the statistics you gave us. Could you talk to us about the concrete experience of the Netherlands? The phenomenon is when there was publicity about the suicide methods. The number of suicides increases in a given country with people who have a mental illness, who are particularly vulnerable, and who use that method. It's not a substitute, but these are people who wouldn't have died if that publicity hadn't happened. And what happened is there were photographs and descriptions. The case of a young woman who received MAID for depression. And because this was publicized in the subway in Montreal or on Jacques Cartier Bridge or in the metro, but the numbers, once again, the trend was an increase right away. I only have 15 or 20 seconds. It increased to the figures that I gave you. Within 1 year, instead of 2 cases, there were 238 deaths. The following year, 219. These were young people, mostly young people, women who lived alone, who had a diagnosis of depression, clinical depression, and who made those requests. And the idea is that the message that's communicated to suicidal people is that this is one way to treat your depression. Thank you. Perhaps you could send us that study. Okay, thank you.
Moody for 3 minutes.
Mr. Chair, Dr. Mishara, I have to come back to this because I'm puzzled by what I'm hearing. I want to put a scenario to you. This committee has heard testimony that here in Canada, we should not allow persons with mental illness as their sole condition to access MAID, even when they are suffering intolerably, even if they meet the criteria required, and even if they wish to end their lives, and would and will do so if they do not get access to MAID. Do you share this view, Dr. Mishara?
I do not at all share that view. I have spent my life working in suicide prevention. I have started helplines in different countries, in Montreal. I've worked on the line.
I have another question for you, Dr. Mishara. Paul, you'll get a chance to answer.
Okay,
Is it your view, Dr. Mishara, that people who are suffering intolerably, who have tried all appropriate levels of treatment, all appropriate supports, all of which these individuals deem to have failed, who continue to suffer, is it your opinion that they should keep trying these failed treatments? They must wait for the realization of some research to come in the future, perhaps. They must continue to live with this intolerable suffering. Is this your view, Dr. Mishara?
I believe that, first of all, the treatment for suicide involves a human being caring about them and believing that they can find hope regardless of this hopeless situation they feel they are in, and embarking with them on helping them get help and support they need. If you look at the reasons people give, it is not because of the symptoms of their illness. It's often because of loneliness, inability to be in a relationship and have a job, feeling the stigma of a mental illness and its impact along those lines. If you look at the reports of why people are asking for MAID, even not for mental illness, it's almost never pain, like physical pain. It's an emotional suffering which is equally a result of living in our society where when you have a mental illness, you can't get a good job, you don't, people abandon you.
Thank you for that.
Thank
I
you.
just have
Thank
one
you,
more
Senator.
question.
Your 3 minutes is up.
Okay.
Senator Osler for 3 minutes.
Thank you, Chair, and thank you to both witnesses for being here today. My question, I'm going to start with Dr. Socklingham and go to Professor Mishara if there's time. This committee has heard testimony from different experts on what they think patients should do, and less from patients with lived experience, particularly those who are in support of MAID where mental illness is the sole underlying medical condition. It's a two-part question. First question, Dr. Sockling, are you aware that there are people with lived experience with mental disorders who have publicly stated a willingness to bring a different perspective than those who have been invited to appear before this committee? Second question, would you agree that having people with lived experience, with a diversity of views and experiences and expertise before the committee would allow the committee to better meet its obligations to make recommendations on this difficult issue?
Thank you for that question. I would say in my experience, and again, in the process of our own journey at CAMH in our recommendations and statements to previously and currently, we have tried to engage the most diverse patients, including people who have stated with lived experience that they're in support of MAID for mental illness. I think we are still left with the challenge of we're not arguing grievousness from that standpoint, but the definitions of irremediability and the differentiation of is that request occurring or people seeking MAID in the context of their mental illness, is that differentiated or can that be differentiated from suicidal intent as part of the illness itself? So I think from that standpoint, your question is, should we include people? We should always, and we have tried to at CAMH as well. So I would agree. I still think we are still stuck with some of the, as an assessor for MAID, I'm an assessor for MAID, that I am still stuck with the struggle based on the lack of evidence or guidance or objectiveness to feel comfortable that we're making a decision and be able to prognosticate for an individual what their long-term course would be. So I think that's the tension here. So the answer is yes, we should have diverse views.
Thank you. And from what I've heard from you, you said, yes, you're aware of people with diverse opinions and lived experience, diverse opinions. And at CAMH, you did try to hear from a diversity 100%. Of patients with views.
100%.
Thank you. And Professor Mishara, same question to you.
Professor, you only have about 5 seconds. So briefly, Anthony.
I appreciate how much people care about the suffering, but suicide prevention works, and every single person who I have spoken to and with who is suicidal felt exactly like described,
I understand, and
they got,
cut you off.
most of them got hope.
But my question was about centering
Thank you, Doc.
Thank you.
Thank you, Senator Osler. Your time is up. Senator Wells for 3 minutes.
Thank you, Professor Mishira. In your previous testimony to this committee in 2022, you stated that in the Netherlands, only 5% of MAID requests for a mental disorder are granted, and that even in, quote, even in medical cases of terminal illness, 40% of the requests are refused because the doctor believes there are ways to treat suffering, and hardly any of those refused repeat their requests after trying the treatments, end quote. So my question to you is this: if you know whether these statistics are still the case in the Netherlands, I think you went into that a little bit, and if so, wouldn't that demonstrate that the Netherlands actually has a robust safeguard system for MAID MISUMC that Canada can learn from?
Well, even though that's gone down a little bit, it's 3% of the requests are for MAID for mental illness are approved now, but there is one clinic which gets 85% of the requests, and they approve 13.6% of their requests. The problem is that this was sort of under the radar. There were a couple of cases.
I don't want to go too much into that. That's maybe not relevant to our example here in Canada. So the question was, is there anything you think we can learn from the Netherlands experience? You said MAID requests are actually going down from the Canada experience.
Well, they're not. The number for mental illness is skyrocketing now. But and the number the percentage they're approving has gone down about 40%. But the number of it's gotten to the point where it's an epidemic of young people mostly.
I only have limited time, so you don't think there's anything then Canada should take or learn from their
Well,
experience in the
there's a
Netherlands?
danger to offer MAID for mental illness because this communicates to a vulnerable population where in many instances suicidality is a symptom of their illness. The desire to die is a symptomatic of the illness, and what it's caused is a phenomena where it's being considered an alternative to treatment.
Are you saying that talking about MAID can lead to a contagion of people wanting to pursue MAID?
Showing any death by suicide or by MAID for someone with a mental illness to vulnerable people who have a mental illness and have considered suicide and will increase the number of people who will die by that method and the number of people who wouldn't have died who would then choose MAID. This happens if you talk about a suicide on a bridge or the metro or someone with a mental illness.
So is there actual research that focuses right on MAID?
Senator, your 3 minutes is
If you
long.
could send that to
Senator,
us.
your 3 minutes. Yes, if you could send us all of these studies from Holland, we'd be, as we previously mentioned, we'd appreciate
I shall do so.
We go to the second round of questioning. Mr. Cooper for 3 minutes.
Thank you, Mr. Chair. Dr. Socklingham, consistent with the testimony of other psychiatrists who came before this committee, you indicated that there is no specific scientific way to predict the future course of mental illness. So, given that, would it be fair to say that any prediction would amount to a clinical hunch?
I would say clinical judgment is where we are basing any kind of prediction at this current time. And as I said before, there's research underway for several years to try to explore indicators to help us prognosticate better, but we're a long way away.
And it would be fair to say that it's quite common for psychiatrists to disagree amongst one another on the future course of mental illnesses. Is that fair?
I would say so, and even the diagnosis itself, as others have highlighted as well, that there are studies showing differences, including from the initial field studies of the DSM-5, for example, that there are differences in diagnosis and that they change over time.
And so given the difficulty in predicting irremediability, the fact that there is no scientific objective way, would it be fair to say that if this expansion were to move ahead, there would be a high rate of error in which persons who could get better, who could go on to lead a healthy and happy life, would have their lives prematurely ended? As Dr. Sanu Gained said, it would be akin to flipping a coin. Would you agree?
Yeah, I would say we would be using clinical judgment, and there would be, if we were to go forward, that there would be times where there may have been a chance to provide treatments that people may not have had access to or not been aware of, and that there may be times where people's illness may have improved, but we may have predicted incorrectly.
And you spoke about the CPA guidance, and you noted that it fails to provide any scientific criteria with respect to predicting irremediability, likely because there are no such criteria. The CPA guidance does use the practice standard from Health Canada, but that looks back on a retrospective basis. You would, I take it, agree that that's insufficient?
That is insufficient, and again, the CPA, I applaud the CPA for trying to come up with guidance, but we're limited by the literature and the evidence. And the evidence is based on retrospective data, and it's a process document as opposed to a criteria or an objective assessment.
Thank you. Mr. Maloney for 3 minutes.
Thank you, Chair. Thank you to both of our witnesses. Dr. Sockingham, I will continue with you. You said at one point that any such diagnosis is entirely subjective when it comes to mental illness, I believe. And is that because, do you say that to some degree anyway, because the symptoms are subjective?
Well, the symptoms are not subjective, and I wouldn't say entirely subjective. We have diagnostic criteria that are based on symptoms and have evolved over time. But I will say we don't have objective markers. We don't have a test and those markers don't necessarily are limited to diagnosis. They're limited to even prognosis. For example, in certain neurological conditions, in cancer, we can prognosticate who's going to respond to what treatment for how long and what their duration of illness might be, and where death might be.
I think we're saying the same thing. You just put it much
Yes.
better than I could have. I mean, when people come to you or another psychiatrist with a mental health condition, you're relying on information that they are conveying to you verbally. There are some indicators or some markers that you can use, but unlike a physical medical condition where there's an MRI or an X-ray or something, there's not as much physical evidence available to you as a diagnostic tool. Is that right?
That is correct. We have some data points, but nothing that would definitively be something we can hang our hat on for this particular discussion today.
And that's what's going to lead to the inconsistent diagnosis that Mr. Cooper was alluding to, because if somebody has terminal lung cancer and 10 doctors examine that patient, they're all going to agree the patient has lung cancer. If 10 psychiatrists examine somebody who has a mental health condition, you're going to get different diagnosis, aren't you?
That is correct. It happens in our clinical care. When people are
and
admitted to
very
different
rarely
hospitals.
are you going to get 10 out of 10. It could happen, but it's very rarely, and it's not going to happen in the vast majority of cases. Is that fair?
That is correct.
Okay. All right. So I want to talk about another thing. We've been talking about consensus at this committee quite a bit, and I think at times people are confusing ethical consensus with medical consensus. In the condition where I'm talking about with the lung cancer, you will get a consensus, and if there is a lack of consensus in the medical community or in the general public about whether to proceed with MAID, it's basically on an ethical issue versus a moral issue. Whereas when you're talking about mental health, really the consensus you can't achieve is the medical consensus. Is that fair?
That was what I was referring to in my statement. Correct. It's the consensus on irremediability, consensus on differentiating suicidal intent versus a request for MAID or persistent desire to die.
Which takes me to my third point. Okay, we're talking about equal rights on MAID for people with mental health versus physical conditions. Everybody agrees they should have equal rights, but lacking the ability to have this definitive diagnosis, it's hard to provide that those rights are safe. Is that fair?
Exactly. It's safe, and I would just underscore the accessibility.
Protected is a better word, yeah.
Yeah, protected, and also the accessibility to treatments that are effective.
Thank you, Mr. Maloney. Madame de Bellefeuille pour 2 minutes.
Ms. de Bellefeuille, 2 minutes. Thank you, Mr. Chairman. Professor Mishara, we agree that not everyone who has a mental illness problem has suicidal ideation or wants to commit suicide. We have agreed since we talked that there's a close link between a mental health problem and a desire to end one's life. In my practice, I've met people who have mental illnesses, and that's their only illness, and they don't think about suicide. They want their suffering to end. They want good treatment. They want to get good care. So it's not necessarily a cause and effect here. Sometimes I think that some want us to think that to prevent MAID for people whose only diagnosis is mental illness is automatically linked to suicide. So am I wrong to think that not all people who have a mental health issue think about suicide? Is it normal that a person who has attempted suicide, who has been treated, listened to their psychiatrist, took the medication, could have the choice of dying with dignity. It's not the same thing. Seems to me we're confusing things, Professor Mishara. We're creating links that seem to me a little tenuous. I'm sorry, I'm going to wear my researcher's hat again. The research indicates that in Canada, over 90% of people who commit suicide had a diagnosis or could have had a diagnosis of mental illness. Okay, well, therefore, 10% don't have one, and they have rights. Thank you.
2 minutes.
Thank you, Mr. Chair. My question is for Professor Mishara. Would you agree that a parliamentary committee tasked with making recommendations on this important and complex issue should have before it not only the full range of expert evidence, but also patience?
Point of order.
Point of who is it?
It's mine.
Mr. Long?
Mr. Chair, I'm rooting this in Chapter 20 of House of Commons Procedure and Practice. This committee had set out through the work of the subcommittee a very robust plan, including people with lived experience. The scope of this committee is not to review or ask witnesses to weigh in on how to structure parliamentary committees, which is what the senator is now devoting her second round of questioning to. So the line of questioning is out of scope, but it's also misrepresenting the facts of how this committee is undertaking its work.
I would suggest, that, and the chair has some discretion over this, I think the line of questioning is broadly related to the topic under discussion. She has briefly 1 minute and 35 seconds left. I don't think it's going too far out of line to let her ask her question.
Thank you, Mr. Chair. So to be brief, Professor, to allow you the optimal time to answer, can you tell us about hearing from, in your experience as a researcher, hearing from patients with a diversity of experiences?
It certainly enriches our understanding of how to proceed and better help people because it gives a sense of their whole life and all the complications of their life which are associated with their suffering, because the suffering with someone from a mental illness, I agree it can be just as acute or worse than suffering from a physical illness, but it is not because of the symptoms that are usually. It's usually because the whole constellation of living with a mental illness and frustrations and getting help and so forth. And it's more complicated because many diagnostic categories, diagnoses, one of the symptoms, like of depression, is hopelessness. It's a symptom of the illness, so that no matter how good things seem, you're going to think it's hopeless. I'm never going to feel better. And this is related to the illness, which is not being adequately or correctly treated at that point in time. So it certainly can point to things a little out of the technical scientific discussion, but as a society, how can we better help people with a mental illness so they won't feel so desperate, not just in terms of mental health treatment, which is very difficult to get in Canada, but also in terms of all the other aspects of the life of someone with a mental illness, which is profoundly influencing their ability to live and have a good life in Canada despite their illness.
Thank you, Doctor.
I have a point of order as well, just before we...
Point of order.
I just want to make sure I correct the record. Last night, we had someone with lived experience, so we need to correct the record from what the senator just said. Thank you.
Point is noted. Senator Wells for 2 minutes.
Thank you. My question is for Mr. Sucklingam. Since the Canadian Psychological Association wasn't invited to this committee to discuss their guidance, I want to ask you, what is CAMH doing to develop the objective markers to determine the mental health condition required?
Well, CAMH, I'll take that in two parts. So CAMH, one of the reviews cited came from CAMH, and the recent review is under publication on the difficulty of differentiating suicidality versus requests for MAID. And so that's part of the work we've been undertaking the last couple of years. And we have another review and synthesis of the literature around irremediability that has informed our statement. Secondly, we are a research, academic research hospital, and we are conducting numerous studies, including looking at youth and following youth over time to look at trajectories of people and differentiation of illness, and also looking at more personalized care in terms of treatment response. And then lastly, we are leading, and including just yesterday, published a paper on treatment-resistant depression and treatments and what can be effective for people who have not responded to other treatments before. And we will continue to do that research and work to develop those treatment options for people who may not have responded to many of our traditional treatment forms.
Great, thank you. Do I have time? Okay, thank you. Dr. Sockingham, you said in a New York Times article published in 2023 that CAMH has been clear that we have concerns about expansion at this time when talking about MAID for MI-SUMC. So based on your testimony today, are you correct that you still don't feel that we're ready for this extension? And if so, do you think Canada will ever be ready?
I'll just reiterate my statement. I do not think we are ready at this time, and I don't think so in the foreseeable future, to be honest, because we do need further research, evidence, and to evolve our approach for both assessment and treatment for mental health, both as an individual and for the system at large. Will I say that ever? I won't go that far. And I'm saying we can't predict the courses of mental illness. I'm not going to predict the future of psychiatric research at this time.
Thank you. Thank you, Dr. Sockingham and Professor Mishera, for your valuable testimony. We appreciate your coming out tonight. And with that, we'll suspend and wait for the next group of witnesses to arrive. Order. For the second hour, let me introduce the witnesses. In the room, we have Mr. Neil Belanger, Chief Executive Officer of Indigenous Disability Canada. And by Zoom, we have Dr. Roderick McCormick, Professor, and do I have that? Who's disability, Indigenous disability? I think Professor as an individual, right, Dr. McCormick? You're here as an individual.
That's right.
Thank you. So maybe we'll start in the room with Mr. Belanger. You have 5 minutes. With about 30 seconds left, I'll hold up the paper, and as we discussed, you can go a little over time.
Thank you, Mr. Chair, and thank you.
Chair, is it possible for us to learn a little bit more about our witness? We have in front of us a person who is a professor. Do we know anything more that you can share with us about this esteemed witness in front of us?
Professor Mr. Belanger is Chief Executive Officer of Indigenous Disability Canada. Is that who you're talking about? Mr. Belanger, that's all the bio I have on Mr. Belanger. If Mr. Belanger would like to add some remarks about a bio, however, that would be at expense of other parts of his speech. So.
That, Mr. Chair?
No, I think, it's his time. It's his 5 minutes. He can do it as he pleases. It's your 5 minutes. It's not the senator's time to ask questions.
Thank you.
She can ask during her 3 minutes if she'd like to ask the questions.
So thank you again, committee, for having me here. My name is Neil Belanger, and I'm a member of the Laxell clan in the House of Nigadane of the Gitxsan Nation. I'm also the Chief Executive Officer of Indigenous Disability Canada, or IDC. IDC is a national Indigenous cross-disability organization that has provided disability-related supports and services across Canada for the past 35 years. Before I begin, I would like to recognize and thank the Algonquin and Anishinaabe peoples whose territories we're meeting on today. IDC was the lead organization working with over 55 national disability groups on Canada's second and third review of the CRPD. From this review, the United Nations Committee on the Rights of Persons with Disabilities recommended to Canada under Article 10, Right to Life, to repeal Track 2 MAID, including the provision to expand MAID to those whose sole underlying mental condition is mental illness. To date, despite 1 year passing, Canada has failed to respond. On a daily basis, IDC works with individuals and families with disabilities from across Canada, including those with mental illness. Our work is to assist in obtaining necessary disability and health-related supports and services. This is so individuals and families can have a good life, where their disability and health-related needs are met. IDC works with thousands of individuals annually, including those who have been approved for MAID Track 2, those who have applied for it, and those who are considering requesting it. Individuals we have worked with includes those from the deaf community who are approved for MAID Track 2. They only requested MAID due to the denial of requested technology and disability accommodations while in the correctional system. This denial resulted in their inability to participate in group sessions and activities and communicate with their legal representatives, causing increased mental stress, increased isolation, and in turn eroding their will to continue. Other individuals IDC has and is currently working with have conveyed that they're intending to apply for MAID due to the lack of inadequate housing, discrimination and racism experienced in healthcare, and the general lack and inadequacy of disability services and supports on most levels, all of which have greatly impacted their mental health and their desire to go on. IDC has been in contact with persons approved for MAID Track 2 who, despite being approved for state-assisted death, hadn't been assisted in obtaining their disability tax credit. The DTC is a gateway benefit for other benefits, including the Registered Disability Savings Plan, Canada Disability Benefit, Canada Workers Benefit Disability Supplement, Canada Dental Plan, etc. These are all benefits that could be significant in alleviating a person's suffering. It seems unimaginable that state-assisted euthanasia could be facilitated and approved, while at the same time the individual received no assistance before, during, or after their MAID assessment and accessing their DTC. MAID Track 2, including MAID where the sole underlying medical condition is mental illness, has been framed by pro-euthanasia assisted suicide groups as a so-called equality right. This equality right, however, is reserved solely for those that considered to be unequal. No other group is afforded access to this state-provided euthanasia, regardless of their suffering. No, this equality right is only for those who are commonly portrayed as less than, defective, wanting, and people no one would ever want to be. Overwhelmingly, past and present committee members have heard from expert witnesses, ranging from persons with disabilities, Indigenous leaders, clinicians, and disability organizations, all of whom voice that the reasons many persons with disabilities and mental illness request or even consider Track 2 MAID is due to lack and inadequacy of available services and supports. These gaps in services leaves persons with disabilities and with mental illness in isolation, frustration, and desperation. Life for many becomes too hard, and again, not because of their disability or mental illness, but because of the systems they are forced to endure and the suffering that those systems inflict. We can fix those systems and ensure that persons with disabilities and mental illness have the necessary supports to live a good life. But in Canada, we're opting to present them with state-assisted euthanasia as an acceptable and normalized alternative. Persons with disabilities and mental illness taking or contemplating MAID due to lack or withholding of necessary and adequate supports and services is not a voluntary action by them, nor is it made freely or as some might suggest. It is in fact a response to tactical omissions within our disability, health, and social systems. It is a result of external pressures, and it is the definition of coercion. During the previous and current sessions of MAID, the AMAD committee have heard from expert clinicians have overwhelmingly testified that mental illness can never be deemed irremediable, that there's no standard medical tests or the existence of any specific clinical criteria to determine irremediability. Simply put, if this expansion is allowed, there is no way to predict that the individual euthanized could have not led a good life and a full life once proper supports and treatments were in place. There are no safeguards, policies, or procedures that can be put in place to correct this.
Thank you. Dr. McCormick for 5 minutes, please.
Great, thank you. Sego, my name is Rod McCormick. I'm a Mohawk and professor and research chair in Indigenous Health at Thompson Rivers University. I'd like to thank the committee for the invitation to provide input on this impending legislation that has literally life or death implications. For context, I'm talking to you from my house and my partner's reserve of Kamloops to Secwepemc in Kamloops, BC, where I'm director of an Indigenous research center called All My Relations. Academically, I've been recognized as a distinguished university scholar and a fellow in the Royal Society of Canada. Finally, I'm also a mental health clinician who has had almost 40 years of experience as a mental health service provider and consultant for Indigenous peoples. One of the consulting projects I'm working on that has pertinence to MAID is the development of a provincial Indigenous suicide prevention life promotion strategy for BC on behalf of the First Nations Health Authority. Expansion of MAID for mental illness goes against every effort I have made in my work in suicide prevention and life promotion. In my work with clients suffering from mental illness and mental anguish, I have worked with numerous clients who were suicidal. Upon recovery, many of them shared with me what they learned from this challenge in life. They realized suicide was a permanent solution to what proved to be a temporary problem. They realized they were not thinking clearly at the time they were suicidal. They realized they had self-isolated themselves from friends, family, and those who could help them. They realized they were looking for an easy way out. They admitted that they were not aware of the many treatment options that worked for others, and they realized in retrospect how their suicide would have devastated their friends and families. From a study I conducted with 25 Indigenous people who recovered from being suicidal, it turns out responsibility to others is a great protective factor. Although I obviously cannot speak for all Indigenous peoples, the pattern I'm seeing in the expansion of MAID is an abdication of responsibility by the Government of Canada. Instead of making every effort to provide the range of mental health services needed by Indigenous peoples to overcome their pain, Canada is instead imposing upon them the burden to decide if they should choose a government medically sanctioned permanent solution to what could easily be a temporary problem. Many Canadians may not realize Indigenous peoples are a vulnerable population. Due to our history of colonization and ongoing oppression, we have very high rates of unresolved trauma, unresolved grief. We watch our relative experience death in custody in the care of social services and the justice system. We watch our people die of complex and higher rates of disease than the general population. Our suicide rates are on average 3 times higher than the general population. Many Indigenous communities are affected by minimal economical and employment opportunities, remoteness, accessibility barriers, transportation issues, limited access to necessary disability, health, and social services, and their associated professionals. When Indigenous peoples are one of the most vulnerable sectors of Canadian society, it seems immoral to provide an easy path to death versus the mental health assistance that other Canadians receive. MAID is culturally biased, in my opinion, in that it emphasizes individuals' right to autonomy and choice without taking others into consideration. Other cultures do not place such a high value on individualism and autonomy. By encouraging Indigenous peoples to put individual rights ahead of collective responsibilities, Canada is, in a sense, perpetuating colonization. What do I mean by abdication of responsibility? If we don't provide the care that people need, then we shouldn't be offering them death as an alternative to the care. There's a failure to understand that appropriate and timely help is the key to survival. And instead of making every effort to provide range of mental health services needed by Canadians to overcome their pain, Canada is imposing upon them the burden to decide as an individual to choose death instead. Figuring out how to address mental illness for the vulnerable is difficult and costly, but to resort to the easy solution of lethal injections is, in my opinion, irresponsible and immoral. Responsibility is the ability to respond, literally to be response able. It seems that governments, provinces, and communities do not feel like they're able to respond to the mental health needs of Canadians if they're now defaulting to doctor-assisted suicide. How can we as Canadian citizens empower our communities and governments so that they feel able to respond? Until we figure that out, I urge the Canadian government to continue to prohibit the use of MAID for mental illness and to instead take the responsible path of improving the mental health services available to Indigenous peoples and to all Canadians.
Thank you. Almost right on 5 minutes. Ms. Jensen for 5 minutes.
Thank you, Dr. McCormick. You're doing the hard work of building a suicide prevention and life promotion strategy in Indigenous communities, where your focus is on connection, culture, and keeping people alive. But at the same time, the broader system is moving toward offering assisted death for those very same mental health struggles. In communities where decisions are deeply connected to family, culture, and future generations, that seems like a very confusing message. So how do you explain that to the communities you serve, that you're working to prevent suicide on the one hand, while the government is expanding access to state-sanctioned death for mental health conditions that your strategy is designed to address? Oh, you're on mute.
Yeah, you're right. There's that conflicting message. I don't have any answers. I think I don't have any easy answers to that. Why one system is pushing for one thing and why another. I mean, the culture is not. It's just not. It's not the way we operate on an individual basis like that. Yeah. So good point. I don't really have an answer to it.
And many Indigenous leaders have spoken about how past systems opposed outside values and decisions onto their community, often without fully respecting those cultural frameworks around life, responsibility, and care. And when we look at MAID, it's built largely around individual autonomy and personal choice. But that's not how many Indigenous communities understand decision-making. It's often relational, tied to family, community, and future generations. So do you see a risk that expanding MAID, especially for mental illness, could reflect a similar pattern of imposing an individualistic framework onto Indigenous communities?
Yes, definitely. I got that right. And that cultural conflict, the focus on individualism, I think it's one of the reasons why there is mental duress and struggles by people, because it just adds to the pile that the media and everyone, the health system, educational system is saying, no, you have to be an individual. You have to master your own environment. It's very biased and culturally encapsulated view of how you should function in life, and that goes against a lot of community, family, traditional values.
I attended a Métis Nation BC presentation where Dying with Dignity was presenting MAID as essentially another treatment option, framed as compassionate and loving. But at the same conversation, Shirley Sullivan, who was a Métis nurse practitioner, pushed back and said clearly, MAID should not be the alternative for a lack of services. Because when a system presents death as a solution in communities that are still fighting for basic access to care, it's not a choice, but more like something being introduced into a gap. So from your perspective, is there a risk that framing MAID this way, especially where services are lacking, reflects the typical pattern where outside systems and values are being layered onto Indigenous communities instead of addressing the underlying needs?
Yeah, absolutely. Yeah, when we're given those messages, it's more of the same, it seems. Yeah, I'm sorry, I wish I could give a more optimistic answer to your questions, but I totally agree with what you said.
So in your estimation, how many Indigenous Canadians suffer from a mental illness and could be at risk of MAID with this expansion?
I don't have stats in front of me, but generally we have higher rates of mental illness, and certainly that's reflected, some of the symptoms in terms of addictions and incarceration and the suicide rates. I mean, it's 3 times higher. It's much, much higher for the North and remote communities, for Inuit, for males versus females, but it's still a shocking discrepancy between what the rest of Canadians experience.
Yes, and we're definitely hearing that from professionals. It's a really a regional problem where, certain areas you can get access, many areas you can't. So I appreciate all the work you're doing. Thank you.
Thank you.
Ms. Jensen, Mr. Grant for 5 minutes.
Thank you, Mr. Chair, and I want to thank all the permanent members here for the work they're doing at this committee. It's a very important topic, and thank the witnesses for coming forward. Mr. Belanger, Dr. McCormick, my name is Wade Grant. I'm from British Columbia. I was actually formerly the First Nations Health Council Chair, and I know that both of you have had interactions with the First Nations Health Authority. I grew up on a First Nations reserve where many of my relatives died way too young because of suicide and other things, and we know far too often First Nations and Indigenous communities will have to put forward a state of emergency because of the overwhelming amount of people, especially the young people who, in your stats, it's the number one cause. Suicide is the number one cause of Indigenous youth and those under 44. It's 9 times higher in the Inuit community and 3 times higher for First Nations and 2 times in Métis. As I grew up and went through that, it shows that the people are not getting the treatment that they're searching for, and you've said this in your statement today, Mr. Belanger. And I'm just wondering if you know why. Will you explain a little bit more about how their needs are not being met or being partially met, and also what comes into play when people actually don't seek it because of the mistrust they've had for health.
Sure, and thank you for the question. And in a former life, I was the executive director of health for First Nations in the North. We put in programs. We had an epidemic of suicide crisis in the northern BC. We worked with 4 nations to put together programs to try to address those things. The unfortunate aspect is that funding within First Nations communities is often inadequate to deal with mental health issues, to deal with home care. There's very limited disability-related funding that is provided, and access to clinicians is very difficult. You look at 6 months to a year to longer in in northern communities even longer then. The distrust that's been, with government and government agencies still exists as well. Anti-Indigenous racism in Canada has gone up exponentially over the last couple of years, and racism within healthcare is rampant. We know the cases of Joyce Echewan. We know Keegan Combs. We know about the In Plain Sight report. So there's all this apprehension to go out and seek something outside the community where your family is, where your supports are, where you are, part of a community where in other communities and systems that you may not even be welcome to. So again, has been noted, limited economic opportunities within communities, limited infrastructure. Some communities are dealing with massive housing problems. And again, the whole thing is the lack of availability of mental health services. And it's a struggle that has continued for a long time.
Thank you, Mr. Belanger. And Dr. McCormick, you'd mentioned that Indigenous rights is a collective right, and sometimes we far too often look at the individual right. And when I was on the First Nations Health Council, we issued the 10-year strategy on the social determinants of health, which was adopted by 84% of chiefs of 176 chiefs. Back in 2023, and we talked about the community-driven, nation-based approach, and that's that's the two-eyed seeing approach for First Nations to be able to make sure that the health and well-being of their people comes home to them. Maybe you can expand a little bit about the work that you've done on that and how that's working when First Nations culturally sensitive and traditional ways of healing have been brought forward.
Yeah, there's been a growth of movement towards traditional healers and healing and ceremonies. A number of the health centers in BC have traditional healers as part of their staff. Ceremonies have been so valuable in people's healing. Those are being brought back. So there's hope for the future, but a lot of it is what we have to do ourselves as Indigenous communities. I'm a researcher, and I often say research is the search again for what we once knew, because we had some really good systems in place before colonization, and we've tried for years now to get help, both from federal and provincial governments and organizations, and a lot of money has been spent, but not a lot of help's been provided, it seems. So I believe that the secret is community empowerment, community engagement, ownership, and self-determination in many ways when it comes to mental health services. We're going to need some finances to do that, but I think we have to find the solutions ourselves because it's government just hasn't been able to do it for us.
Thank you, Dr. McCormick. Madame de Bellefeuille pour 5 minutes.
Madame de Bellefeuille for 5 minutes. Thank you very much, Mr. Chairman. My name is hard to pronounce for an Anglophone. There's many vowels in it. I wish to thank the witnesses for their testimony today. I'm a member of Parliament that represents the Mohawk community of Akwesasne, which is within my riding. Because I was sensitized to this issue by the chief, there's a lack of social services and health services, not just mental health, but the whole field of health in these communities. And I would say that there's even addiction problems because of opioid addiction. These are very acute problems in our community. We've discussed it. We deplore the fact that Indigenous communities are not supported better to face these health issues, which are significant. In all provinces, including Quebec, there's a lack of funding, a lack of support in all health sectors. That's why we say that today we would have liked to see, in today's economic statement, new money to be invested in healthcare for people who need it in our communities and in public services of the provinces in general. We were disappointed to see, we even saw cuts within the next few years of the transfers for health and social services. So I can't disagree with you about the fact that there's a lack of services, but we have to broach the subject of MAID. You use the term euthanasia. I don't know if I interpret it badly, but in clinical language or legal language, we talk about medical assistance in dying, not euthanasia. MAID is a request that comes from an individual who's making a decision to choose a method of dying with dignity. So there's palliative care, there's MAID, there's many different aspects to it. There's lethal injection. It's one of many different choices in MAID. So it's not imposed. It's not, I really don't see how this kind of care is imposed on a community. It's offered, and full-fledged individuals can make that choice. So my question, because I'm not a permanent member of this committee, I have not heard all previous testimony, but I really want to better understand and I want to learn. Can you tell me whether, for example, there are many people in your communities who have an incurable, persistent disease such as cancer or MS or something else? In your communities, do they request MAID to get relief from their suffering and die with dignity? Or is this something that you do not request because of your culture or your way of broaching life, let's say?
So for our organization and for me as the CEO, we deal with disabilities and we're dealing with track 2. So I don't know the frequency of within the Gitxsan Nation or any nation of how many people might be requesting MAID or taking MAID under track 1. I haven't heard any from my chief or the members in my family. Doesn't mean it doesn't happen, but I just don't have that expertise. And to go back and respectfully, I mean, listen to your comments and I appreciate them, I do. But medical assistance in dying is a euphemism that was put in place to, it's non-culpable homicide in the criminal code. That's what it is. So, and this is part of the process of making something where we have, Indigenous and non-Indigenous people with disabilities that are burdened down by the pressures, the lack of services you just described, where they are to a point where they are, making a decision, which I believe is coerced, even though people say it is a decision that they make themselves. But when you have all these pressures of everything else, so
I don't want to interrupt you, it's impolite, but right now, MAID for people with mental health disorders is not accessible. We're discussing whether it should be broadened. Right now, MAID exists for physical health problems such as cancer, when there's predictable end of life. So what I'm asking is whether that kind of care is requested in your communities.
Sorry?
You just have a very short time. She's gone through her.
Again, under track 1, I couldn't give you that information.
We'll go on now to Senator Delphone for 3 minutes.
Thank you very much for the members of the panel. My question will be for Mr. Bélanger. First, I recognize you came before us in 2022, and we worked together to have the recognizance of the awareness, the Indigenous Disability Awareness Month, 9 years, well, almost 12 years ago now. So you've been involved in that for long. At the time when you appeared before us, you said in 2022 that the federal government had not consulted with Indigenous groups and nations before pushing for MAID. And you said that, you thought it was not really UN declaration compliant or the UNDRIP Act now. So, but since 2022, was there some consultations with the Government of Canada or the Health Canada and the Indigenous groups?
There has been. I think in 2024, I think it began, or 2023, I'm not sure of the dates. But Health Canada started to do an online consultation and provided some funding to different disability groups to, I think it was called End of Life, the Indigenous perspective there. So, although it happened, the online report, as I'm sure you know, Senator, it was on for a year. It had to be extended because of lack of uptake. And at the end of the day, they had 250 respondents across Canada, 50 of which that they eliminated. The population of Canada in 2024 was 1.8 million that identify as being Indigenous. So the respondent rate was like 0.001222%. So, I mean, I guess you could consider that a consultation. I don't know if it's that valuable. We actually met with Health Canada in relation to that. We gave them a 6-page document about our concerns about the online consultation. We had a meeting with them as well to address our concerns. It was a cordial meeting. I wouldn't say it was a productive meeting, but it was cordial. And they offered us, you know, the possibility of having a contract to do more consultations. We asked that if we did that, then we would talk about the history of the AMAD committee. We'd talk about the recommendations. We talk about the implementation of MAID, including recommendations from mature minors and advanced directives. And I know that's not part of what we're looking at today, but we wanted to give the whole view for our communities and for the people that we serve so that they have an informed knowledge, so they can answer questions with an informed, you know, more informed than what the survey had provided. We never got a call back.
Sorry to interrupt, there's almost no time left, but at the time you were also stressing the fact that you had difficulty to access mental support and mental. Did the situation has improved for the Indigenous communities?
In accessing mental health services?
Yes.
I don't think so, no. Not from our experience as a service provider, no.
Thank you.
Thank you, Senator Delfond. Senator Moody for 3 minutes.
And I'd like to thank Professor McCormick for sharing your areas of research with us and for helping us understand all the work you've done in the past. I'd like to ask you 1 or 2 questions around this work. Would you agree, first of all, in terms of helping me understand, that there are Indigenous peoples and communities across them, they hold quite a wide range of views on MAID, that in fact Indigenous peoples there are Indigenous people who request, who have been found eligible and who have received MAID, that this is happening on reserve and in communities, and that there are Indigenous MAID assessors and providers in Canada. Are you aware, and would you agree that this is the existing situation right now in Indigenous communities here in Canada?
Yeah, I as my colleague mentioned earlier, the report that was done looking at the experiences of Indigenous people in MAID, it pointed out that a lot of people didn't know about it or had very little knowledge about it, so it was easy to get confused. I think that was one of the findings. Certainly it does exist.
About you and your knowledge, yes.
Yes,
you're aware of this, right? Correct?
Yes.
Okay.
Yes.
And I'm just following up. You're aware that there are Indigenous people and providers who believe that exclusion of MAID for mental illness alone is wrong, that they are being deprived of a service. Are you aware of that?
I'm not aware of it, but that makes sense. As you say, there's a lot of diverse opinions, so yeah.
And I guess the final question I have, and this is easy day for you, have you done any specific direct research, studying, consulting with any Indigenous individuals who have wished to have MAID, any assessors or providers who provide the service? Have you done any population studies yourself? Is this an area of research that you have intersected with yourself?
No, it isn't. I've done work in the past looking at suicide recovery amongst Indigenous patients, but not specifically for MAID.
Thank you. End of my question. I cede my time.
Thank you, Senator Moody. Senator Osler for 3 minutes.
Thank you, Chair, and thank you to both witnesses for being here today. And my question is for Mr. Belanger, and it follows on the questions that Senator Delfond had asked about consultations with Indigenous communities. And I take it from your testimony that the level of consultation with Indigenous communities was not sufficient. So my question is, what measures would you recommend to the Government of Canada so that meaningful consultation with Indigenous communities on extending MAID to persons with mental illnesses as sole underlying medical conditions meets the standards set out in UNDRIP?
Well, UNDRIP called for the total repeal of Track 2 MAID, and including the mental illness as a sole underlying condition. So there are no recommendations that I would make to anybody, because if we are going to be consistent with our obligations, our international obligations, it should be removed. We wouldn't have to have a conversation. My recommendation is that we provide quality, adequate, and timely services to persons with mental illness as the sole underlying condition, to persons, Indigenous people with disabilities. That's the only recommendation I can make. I can't make recommendations where irremediability is so divided among clinicians to say, how do we make this more culturally appropriate? How do we make it fit for your community? It wouldn't make sense to do that. We need to act upon the recommendations of the UN. We need to repeal it, including mental illness of the sole underlying condition, and get people the support they need to thrive in their communities, without exception. And there's multiple areas that have to be addressed. It's not just access to mental health services, it's housing, it's conditions of poverty, it's isolation, it's all those things that I'm saying are stacked up and stacked up and stacked up. So no, there's nothing I would say that could make this, or I would say that I would want to see this be a reality.
Okay, so just so I'm clear, you're saying no further consultation at this point?
Well, I'm saying that I'm hoping this committee will make recommendations based upon what the UN has said, based upon information from the last committee, based on from information we've heard here, that we'll honor the UN and our obligations to them, and make recommendations to repeal Track 2 MAID, including mental illness as a sole underlying condition. I can't make recommendations of things that in the future. We have to see what the recommendation from this committee is going to be, and what we're going to do moving forward. Then I can make recommendations, but it will never be to euthanize individuals dealing with mental illness as a sole underlying condition, or persons with disabilities when their basic needs aren't being met. And that shouldn't be, respectfully, anything that this committee should be endorsing as well. We need to deal with the problems that are here today and the deficiencies within the system. This is nothing new. This is a fight that we've been doing for years, as long as other organizations as well. And, the reward for living a life of inadequacy and lack of access to services shouldn't be, what people have described as a dignified death. We need to have dignified lives where people get the support they need to thrive.
Thank you. Thank you, Mr. Belanger. Senator Wells for 3 minutes.
Questions to Dr. McCormick. If you could just clarify me, I'm not sure I heard you correctly when you did your introduction. Are you with Indigenous Disability Canada?
No, you. I'm a professor at Thompson Rivers University and a research chair.
Okay, thank you. So maybe I'll go back to our other witness. Thank you for clarifying for that. And I think you've already clarified some of this. So your position is that Track 2 should be fully eliminated?
My position that any law in the books that targets a chartered protected group should not be on the books.
And is your organization a plaintiff in the chartered challenge to Track 2 currently?
We are.
Okay, thank you. My question to Dr. McCormick then. I think it's safe to say that everyone at this table agrees that every Canadian should be provided with adequate supports, whether it's financial or emotional, to help them with dealing with mental illness. But a majority of the witnesses at this committee have made the false equivalency between requesting MAID and having suicidal ideations. So being approved for medically assisted death and having suicidal ideations are two different things. So, Dr. McCormick, if somebody who has a mental illness is genuinely seeking MAID or additional information on the MAID process, how do you suggest suicide prevention frontline workers address these questions? And for the record, I want to point out that to receive a medically assisted death in Canada, a person has to be eligible under strict rules laid out under the law, and they have to go through a rigorous process for multiple medical professionals to deem them eligible for MAID.
Yeah, the last part you said, and again, I don't have data in front of me, but from what I've read, the safeguards just aren't really there. I mean, my understanding, and perhaps you can correct me, is people can choose whether they've exhausted the options for treatment. They can make their own decision. Say, no, I don't want any of the talking therapy. I don't want this. I don't want that. That's, yeah. I mean, I think there's so many new options out there because I work in the field with trauma recovery and so on, like EMDR, psilocybin-assisted psychotherapy. We're coming up with new approaches all the time.
If somebody was coming to your organization then in the suicide prevention, how do you suggest your frontline workers address questions if somebody's coming to you and inquiring around MAID?
Well, my field is counseling psychology, and we spend a lot of time talking to that person about different options they have. It would be a lengthy process. I mean, I'm not sure what I think it really varies in terms of MAID assessors as to how much time is spent finding out their story and what they've tried, what they haven't, what their resources are that they have, what the threats are, protective factors. There's just so much that goes into working with someone that wants to die. And I'm not sure that
Thank you.
Would you refer them to Indigenous MAID providers?
Senator, your 3 minutes is up. Thank you. We go to the second round of questioning. Mr. Patzer for 3 minutes.
Thank you very much. And before I begin, Mr. Chair, I just want to highlight that I think it's completely inappropriate for Senator Wells to call people he disagrees with liars at this committee when we have had. Yes, you did.
Order.
Yes, you did.
I did not say those words.
Yes, you did. You said the majority of witnesses in this committee were lying in regards to suicidality.
Mr. Patzer is using up his 3 minutes. Is he pleases? He's on the clock. Go ahead, Mr. Patzer.
Thank you, Mr. Chair, and I will let my comments stand. Mr. Belanger, in regards to your comments you're making about the United Nations, has Canada formally responded to the recommendation that you were alluding to?
They haven't, no.
Okay, and we've been hearing from witnesses already about the Werther effect and the issue of suicide contagion. We have responsible reporting guidelines for media coverage of suicide that the entire suicide prevention field follows. So what is the contagion risk in Indigenous communities, specifically when government legislation says death is a valid medical response to mental illness?
I think it's quite high. And again, back to my life as running health, and again, the suicide crisis that I went through, we worked with 4 different nations because they were experiencing similar things as well. One of the nations said that we were no longer going to have celebrations of life because it highlighted the person's suicide, and other youth and people in the communities would then do that because they saw that as a celebration, people getting together, recognizing that person. They said, no more, we're not doing that anymore. And I think when you portray MAID as, and again, track 1 and track 2 get intertwined all the time, but the stuff that you see online often, and you see, I was there and I was drinking champagne and I was doing whatever. It's not the reality for most persons and persons with disabilities living in poverty, but it gives a message that this is a good escape and this is a way to go, and this is some kind of justification for a life of wanting and not having supports that the end is somehow dignified. I don't think that's true, but I think certainly it influences, to be sure.
Thank you for that. And then you've now sat through about 3 years of these committees. What do you want this committee to put in its report so that 2 years from now we're not back at this table asking why more Indigenous people with disabilities or mental illness have died because we expanded a system that we knew was broken?
I think I would hope the committee would say, look, we've taken a look at this and we've looked at the law and it's targeting, persons with disabilities, individuals with mental illness as a sole underlying condition. Take a look at the spring economic statement today and look at the lack of services and funding that has been put in that too. We have to make changes in Canada to make sure that we're supporting persons with disabilities, individuals with mental illness as a sole underlying condition. This is not a progressive move. It's not an equality right. It's ignoring our responsibilities to our most vulnerable, and we're normalizing this. And once it becomes more normal, we will never get it back. And there will be no government that will come back and say, "Oh, let's make sure that we're adequately funding this, because it also has become this acceptable alternative to proactive, timely, and adequate treatments, supports, and services. This is where we are today, and we need to stop it, because it keeps going forward. It's not going to stop. And we've seen laws in the past that have been on the books for 50 years where Indigenous people have been targeted and things have happened. It took 50 years to get past it, even then after they're off the books, to deal with it, and we're dealing with those today. We shouldn't be in this situation. Take it back. Give the support people need.
Madame Brière pour 3 minutes.
Ms. Brière for 3 minutes. Thank you very much, Mr. Chairman. I wish to welcome both our witnesses. Mr. Bélanger, I heard your answer to the preceding question. I agree with you that improving access to care, improving housing conditions, there are many things, no doubt, that we could work on to improve the situation of people in their day-to-day lives. But do you think that when a person requests medical assistance in dying, they get it automatically?
I'm sorry, getting made automatically?
Yeah. If you ask MAID, do you think that you automatically get it?
Well, I guess it depends on what tracks you're doing, but under track 2, there's a 90-day waiting period, right? And during that time, the assessment period for the person to think about it, hopefully they're getting programs and services recommended to different disability supports, but that really doesn't happen. I mean, that's the thing. And in my case about the individual being approved for MAID, but not even being referred to get their disability tax credit. So no, I don't think it happens immediately. I don't think it happens like right now and that type of thing. I think in some cases lines can be.
I'm sorry, I'm not talking about a span of time. I'm just asking you, if someone asks MAID, do you think that he will get it?
If somebody requests MAID, do I think they'll get it? Well, automatically?
Yeah.
Well, I would hope not. No, I don't think that happens.
I think it will.
No, I don't think that if you just walked in and asked for MAID that you would automatically get it. No.
Okay. Et j'aimerais alors vous entendre.
Therefore, I'd like to hear you again on the integrity of doctors who assess people, who evaluate a file, and who approve or not and request for MAID.
Not a clinician by any sense. I would defer to the clinicians that spoke here, both who are for it and both who are against. There's no consensus on it. So, I mean, if there's no consensus, and I'm not sure what percentage would be acceptable. If 80% thought that it wasn't irremediable, is it 40%? What's the acceptable amount of people that might be euthanized that could have a better life? For me, it's zero. And unless there's 100%, agreement on this, we are running the risk of euthanizing people that could have led a good life. And that's not a risk that I would take personally, because I know the damage it does to families and everything else that have to go through this. So I'm not debating the credibilities of the clinicians, but this the simple fact that they're so divided should give pause to this committee to say, what are we talking about? There's no consensus here, so how can we push forward a law or expand it to something that nobody can agree to? It's not like... Sorry.
Thank you. Je vais essayer encore. Madame.
I'll try again. Ms. de Bellefeuille, is that better? That's perfect, actually. Thank you, Mr. Chairman. So, Mr. Bélanger, please excuse my lack of knowledge of this whole Indigenous issue, but I'm curious by nature. I want to understand. I want to learn. When you speak and represent your group, is this demand you've made to withdraw Indigenous communities from MAID is a motion? Is it a decision by all First Nations and the Inuit? Is this a demand that is meant to exert pressure on the government, or is it more your opinion as a representative of the group for whom you're here today? As a member of Parliament, I never got any communication with my Grand Chief, who asked to be withdrawn from this. So I'm curious, are all the First Nations requesting this, the Inuit as well?
Speak for all First Nations. I don't speak for any First Nation. I don't speak for any of the 53 Inuit community. I speak for our organization and our experience with the people that we serve, who are Indigenous people with disabilities. Our perspective is, of course...
Okay, I don't want to interrupt you, but it's important for me to understand whether this was your opinion, your organization's opinion, or a demand by all First Nations and the Inuit that you're relaying to our committee. But thank you for answering. Professor McCormick, Mr. Belanger didn't have the data on the fact that in Indigenous communities, people are entitled to ask for MAID, which is legal. Do you have any figures about that? Is there a trend? Do Indigenous people use that option under the law?
No, I don't have it. I'm not sure if that data is available. Should be, but I don't have it.
Merci beaucoup, Madame.
Thank you very much, Madame de Bellefeuille.
Senator Moody for 2 minutes.
I guess I want to ask Professor McCormick if you have any data whatsoever that sheds light for us on what is happening with the use of MAID in your communities more broadly.
No, I myself haven't researched it. I've read the report that was done, the consultation. That's the data I have, and it was again, there was like one city per province that was surveyed. So it didn't.
So you're not uniquely in a position where you can judge the validity or have a comparative basis on this particular type of data. You've read it like I have, or anybody else. Would that be?
That's correct.
Would that be true?
That's correct. Yep.
And so, is it reasonable to say that you bring a certain expertise today to this committee, but it does not relate directly to MAID or the use of MAID in communities that you're familiar with?
Yeah, I bring 40 years as a clinician working with Indigenous peoples who are experiencing mental illness. That's what I'm bringing to this committee.
Direct connection with that mental illness to MAID, because you aren't able to give us the information of what that connection might be. So I'm asking for it. Maybe I'm not clear in how I'm asking for it. Do you have a connection for us?
No, I don't have that data. I don't even know if it's available.
Thank you.
Senator Wells for the final 2 minutes.
Mr. Belanger, from the Health Canada report published in December 2025 entitled Indigenous Perspectives on End-of-Life Care, including Medical Assistance in Dying, What We Heard, they reported hearing the following from elders, First Nation, Inuit, and Métis people. Number 1, we need to reclaim our death and end-of-life processes. Number 2, when our loved ones die, we should have the right to bring them home. Number 3, I fear losing the ability to decide for myself. And number 4, it is concerning that there's a lot of misinformation about MAID, end quote. So, Mr. Belanger, I agree that colonialism and Canada's systemic exclusion of Indigenous peoples have led to unacceptable rates of suicide in Indigenous communities. If this is what we're hearing, what I quoted to you from the Government of Canada, from Indigenous peoples themselves, how should we then balance these points of view with the removal of MAID that you've suggested here today for Track 2?
Well, I'd like to know, is it from the 200 people that responded to the survey?
It's from the Health Canada consultation they did.
So it could be 200 people of a population of 1.8 million. And again, as we've heard, I mean, I'm not denying that there may be people in the community that are supportive of MAID, Track 2 MAID or MAID. But if you'll remember from the previous committees, the majority of the Indigenous witnesses, leadership, persons with disabilities, all spoke against it. So, I mean, I can't comment on a survey that has 200 people of a population of 1.8 million. And to say that this is some kind of tangible document that we have to reinforce.
So just, you don't think the document is credible, produced by Health Canada?
I think that it's lacking.
Okay.
I think that the government should do nation to nation as they're supposed to do, and get a good idea about that.
Do you feel that we should, at this committee, have perspectives from Indigenous people who would like access to MAID?
I think this committee should call any witness that they think is relevant.
Thank you, Chair.
Thank you. And with that, I'd like to thank the witnesses, and I would really like to thank them for bringing an interesting cultural perspective to this conversation. And with that, the meeting is adjourned.